Okay, kia ora everyone. I've got 15 minutes to do 3 cases and a bit about neurosyphilis, so I'm just going to crack on. So I'm going to present the 3 cases. I'm going to talk a little bit about neurosyphilis, its natural history, diagnosis, treatment, and follow-up. I thought the cases were interesting because it happened in a small district hospital which had not had a lot of cases or didn't know much about syphilis, let alone neurosyphilis. And all the 3 cases were differing presentations of neurosyphilis which came to different specialties in the hospital at the same time. So it was baffling. Case 1, he was a 61-year-old man with no significant past medical history. He was referred to the psych services by his GP for a 2-3 month history of personality change, visual and auditory hallucinations, speech problems, low mood and self-neglect. On examination, he was found to be confabulating and disoriented at time, and he was found to have significant cognitive impairment. So the GP had actually started him on citalopram thinking he had anxiety, depression, and the family member with him thought he was actually improving on citalopram. So the psych said, okay, do a dementia screen and we'll see him later. But within 2 months, he got admitted under a section under the Mental Health Act because he was getting even more difficult to manage at home. He was living alone, couldn't look after himself. He was threatening neighboring children. He was threatening to shoot them. So he was brought under the Mental Health Act. He had a scan because you always have to rule out organic causes, and mainly because he had the speech problem as well, which the psych didn't think was it could be an organic cause. So his scans were kind of normal for his age, and he had a dementia screen, and he had a syphilis serology as part of the dementia screen, which was positive, and his RPR was 128. Now, those of us who work in sexual health know an RPR of 28 is fairly high RPR. And because he had a positive syphilis serology, he had a lumbar puncture, which showed increased white cells and increased protein, and a CSF-BDRL, which was reactive, and a fluorescent antibody absorption test, which was also reactive in his CSF, which all these findings just mean he has neurosyphilis. So he got treated with IV benzyl penicillin as an inpatient for 2 weeks, and he was moved to a care home which looked after older people with behavioral issues. There was absolutely no change in his mental health after his treatment or his behavioral problems. His RPR dropped fourfold 8 to 10 months after his treatment, and it was decided it was not in his best interest to have a repeat lumbar puncture for follow-up. So basically, he had a diagnosis of general paresis, of insane dementia paralytica, which is what people think when you say you have syphilis. People think, am I going to go mad or crazy because this is the syphilis that people have heard about. And actually, it is pretty rare, especially in the antibiotic era. So it's a meningoencephalitis. In the pre-penicillin era, 5% of untreated syphilis got this, usually 15 to 20 years after initial infection. It's usually insidious in onset. Early symptoms are just irritability, sleep problems, memory problems, personality changes, but late symptoms can be just frank psychosis. And a lot of people are actually diagnosed with a primary psychiatric diagnosis before eventually they find out, oh, actually, this is neurosyphilis. And you can have eye symptoms, the classical symptoms of Argyll-Robertson pupils, which this gentleman didn't have. And if untreated, you'll die within 5 years. The prognosis, if treated, is actually unclear because not many people have been treated. There's no major case series to look at that. But on the whole, people think that if you get treated, then your cognitive decline is arrested. However, it may not improve. My second case is a 46-year-old gay man. It was quite challenging looking after him. It still is. And he's a regular meth and cannabis user. He was admitted with generalized tonic-clonic seizure and decreased consciousness, and he was intubated and ventilated in a tertiary center ITU. He had OD'd on meth the previous day. And he had a lumbar puncture which showed increased protein. I'm not quite sure about the rest of the lumbar puncture findings. But he had an MRI which showed increased signal in the temporal lobes and the hippocampal lobes. And that, if you do infectious diseases, you will know that's also a feature of herpes encephalitis. So that's the other thing, it can mimic herpes encephalitis. So he was treated with IV acyclovir and ceftriaxone, but subsequently his herpes PCR and enterovirus PCR on a CSF were negative, and they stopped him acyclovir. So they were having problems managing him on a ward because of his behavior, and he was transferred to a hospital. And he continued to have headaches, visual disturbances, and his behavioral problems on the ward. And he was missing from the ward so frequent that they decided he could stay at home, so they discharged him within 3 days. But he came back to emergency department multiple times with headaches, confusion, and visual disturbance. And I feel some of his symptoms were not taken seriously, and he got discharged each time because it was put down to his behavioral or personality disorder or his Matthews. Eventually, he got admitted, or he was brought into to the mental health crisis team by the police, with threatened suicide, and he was noted to be very agitated and disoriented in the police cell. So the crisis team, if you refer anyone to psych team, they will not take anyone unless an organic disease is ruled out, and so they obviously referred him back to ED for the medical team to see him, also in the context that he was just discharged having had an abnormal MRI and an abnormal lumbar puncture. It was the psych registrar who suggested, please do syphilis and HIV testing, and she added it onto the emergency medicine bloods, which was subsequently positive for syphilis, which again, a high RPR of 128. So he underwent a second lumbar puncture within a month, which showed raised CSF protein, again, raised white cells, a CSF BDRL, which is reactive, and a CSF fluorescent antibody absorption test. Now, I just want to say a CSF BDRL test is meant to be specific, highly specific, but not very sensitive, whereas this CSF fluorescent antibody absorption test is sensitive, but not very specific. So both of them being positive, this is pretty much neurosyphilis. He had lots of transfers between medicine and psych because the medical wards could not manage his behavioral issues, and the psych ward could not do the 4-hourly IV benzyl penicillin infusions that were needed. So after a lot of argy-bargy between them, the psych team finally took him over, and they managed to give him IV benzyl penicillin on the ward, and followed by 3 doses of IM weekly benzathine. He was, at that point, he was referred to sexual health for contact tracing. He attended my clinic once and then never turned up, but he was under the Mental Health Act. So I was able to get the psych team to do his bloods, which after 6 months of treatment, his RPR was still 128. And so I was a bit baffled. Is this reinfection? And because he was under the Mental Health Act, he had to come and see me as well with the psych team. And he had multiple exposures and multiple sexual encounters in that time since discharge. So I couldn't really say whether this was reinfection or treatment failure, or whether we do another lumbar puncture and see what happens. So we have a great peer group, email peer group. I discussed it in the peer group. We decided just to retreat him and not do the lumbar puncture, but the wires got crossed. He got the treatment with ceftriaxone and doxycycline, and the reason I chose ceftriaxone was the ability for the psych team to give the treatment. So once a day IV infusion was possible as compared to a 4-hourly IV infusion on a psych ward. And then he had some oral doxycycline as well for 4 weeks afterwards. I didn't know about this, but he apparently went for a lumbar puncture because he was referred by the psych team to go in for a lumbar puncture to the medical team, which I wasn't aware of. Eventually, 4 weeks after he had his treatment, I got the results back, which showed all his parameters. His protein was high, but his CSF cell count had decreased, and which is the first indication that your initial treatment possibly worked. But his RPR remained the same, so we don't know whether that was a reinfection, actually. He is lost to follow-up now, so I've not been able to get him back for retesting, and he's not under the Mental Health Act, so I really can't get him. I did see him at, because I live in Rotorua, and it's a small place, and I did see him at a red light once I stopped, and I was very tempted to, ask him to come in, let's go get tested, but I wasn't quite sure about the rules of curb calling in New Zealand, so didn't do that. So that was meningovascular syphilis. That's an obliterative endarteritis. The average time from infection to getting that is 7 years, and you get stroke-like syndromes with a meningovascular syphilis, and seizures are common too. And it's different from normal stroke because you get all these premonitory symptoms like headaches, dizziness, insomnia, memory loss, and mood disturbance months prior to actually having your stroke. Now, Casey, I'm going to go really quick. He was a guy, 59-year-old gay man, referred by his GP with a change in bowel habit and PR bleeding, thought he had rectal cancer. Whatever looked, so when he had multiple colonoscopies and sigmoidoscopies, which all said he had rectal cancer, multiple scans, so he had an MRI scan, a CT scan, a PET scan, which all said he had a tumor, but everyone said with an unusual pattern of lymph node spread for a rectal cancer. But the biopsy, so every cancer should have a histological diagnosis. Obviously, the biopsy didn't show any cancer. There was always chronic inflammation. He had abnormal LFTs, and that's what his showed. So when doctors don't know what they're dealing with, they refer to MDTs, and MDT advised another examination under anesthesia and another biopsy, which again obviously did not show anything. But by then it had clicked onto the surgeon that he was a gay man, and he got offered a syphilis and HIV test, and his syphilis test was positive with an RPR of 256. At this point, because it took him 8 weeks or so, or longer than that, actually around 10 weeks, and by then he developed a full body rash, and he had blurred vision with multiple floaters in his eyes. But because we knew syphilis serology was positive, he got offered a lumbar puncture, which showed features consistent with neurosyphilis. So I'm just going to go speak quickly about ocular syphilis, commonly associated with meningitis, as in this case, and it can affect any part of the eye. Panuveitis and posterior uveitis is more common. Bilateral optic neuritis is also seen, and the risk is high if your RPI is more than 1 in 16. So that's a bit about neurosyphilis. So people think that on an average, people think around 40% will have sinus invasion at the time of infection, but there are schools of thought which think that actually 100% of people who have syphilis will have some sort of transient invasion of your CNS, and automatically you'll clear it. So 80% of people will clear treponema pallidum from their CNS. But the 20% will go on to get asymptomatic neurosyphilis, and the majority of that also your own immune system takes care of it. And early treatment with benzathine will take care of it. But if your immune system can't clear it, then you get early meningeal syphilis or meningovascular syphilis or genital paresis or tabes dorsalis. Now that was the first case of, I've treated many people for genital paresis, but that was the first one with all the classical symptoms that I'd seen. I'm yet to see a case of tabes dorsalis, which is very, very rare. So risk of neurosyphilis, so if you have HIV and your CD4 count is less than 350, then you're at risk, and if you're not on ARVs, you're at risk. If you are anyone with syphilis with an RPR of more than 32, you're at risk. Certain strains of treponema pallidum have more of an affinity apparently to neural tissue, and you're more likely to have neurosyphilis if you're infected with those types. Or your own immune system, so if you have certain polymorphisms in your toll-like receptors, then you're more likely to, for your treponema pallidum infection to progress to neurosyphilis. So what are the indications of lumbar puncture in a patient that you see with syphilis? Commonly it's neurological signs and symptoms, eye or ear involvement. So neurosyphilis is a treatable cause of sudden onset deafness or treatment failure. So late symptomatic syphilis, so if someone has gamma or cardiovascular syphilis, you should also do a lumbar puncture to see if they got neurosyphilis as well. And I have a very low threshold of doing a lumbar puncture in HIV positive patients with syphilis. Now, diagnosis. This is the hard bit. There's no gold standard diagnosis for diagnosis of neurosyphilis. So the CDC criteria, as if you have confirmed neurosyphilis, if you have a reactive CSF BDRL and your clinical signs and symptoms are that of neurosyphilis. But and you can call it presumptive neurosyphilis, and there is where when you need a real good clinical judgment and experience is when your CSF BDRL is actually negative. The next step would be to do a CSF fluorescent antibody absorption test if it's available to you, which it is available in New Zealand. But it's clinical judgment really to make that decision. So treatment, IV benzyl penicillin is the mainstay of treatment for 10 to 14 days. Alternatives are ceftriaxone and doxycycline, which are not mentioned on CDC, but the European and the British guidelines mention them. And also you have to think about Yerix-Excimer reaction, which is a paradoxical worsening of your symptoms with treatment in the first 24 to 48 hours. And the European and the British guidelines talk about giving steroids for the first 3 days if you're treating someone for neurosyphilis or cardiovascular syphilis, especially ocular syphilis. So you can imagine someone who has optic neuritis and you give them treatment and they get a Yerix-Excimer reaction, they will be blind. So having said that, most people who have optic neuritis are probably already on steroids from the ophthalmologist. So you need to think about it. Even though there's no evidence for it. The other thing is there is no evidence for is actually 3 doses of weekly IM benzathine penicillin post intravenous therapy. Some doctors do that because for late syphilis, usually you need at least 21 days of therapy with penicillin, and that's why the IM benzyl penicillin is given weekly. So some people give it after the IV treatment. Follow-up, most guidelines say lumbar puncture at 6 months, and the CSF cell counts are the ones that come normalized first. Your CSF protein and your CSF BDRL tests are the ones that probably become negative the last, and it can take up to 2 years for all the CSF abnormalities to go back to normal. Now, there's some evidence, some papers that are published that if your serum RPR has fallen 4-fold, then your CSF is likely to be normalizing as well. So maybe a lumbar puncture is not needed, a repeat lumbar puncture is not needed at all. So take-home messages, like we're all likely to be seeing more neurosyphilis, especially early neurosyphilis, because we're all seeing a lot more syphilis. Now, I have to say that those were the 3 cases that I saw. This was my the second month into my first job as a sexual physician in New Zealand, so I was gobsmacked. I thought I'd just see a lot of chlamydia, and I ended up seeing 3 neurosyphilis in my second month, and it's been interesting since. We've treated 4 more cases, so altogether we've treated 7 cases of neurosyphilis in Rotorua, which is a small town in, and multiple visits to healthcare teams before diagnosis is made. Multiple specialties and disciplines are involved. And the biggest trouble I have is actually, the biggest difficulty is organizing a lumbar puncture and huge reluctance for people to do it. Now, over the last year, Rotorua physicians have learned a lot more about neurosyphilis, so they're actually happy to take my referral very early on. It's very different when I work in Wellington. And there's challenges with inpatient care because these are well people, don't want to stay in hospital for treatment, so we get the home IV teams of the district nurses involved, delays at every point. And the most difficult bit, I'll tell you, is actually excluding neurosyphilis in someone who's got behavioral issues and has a positive syphilis serology. So those are my co-authors. That's the Blue Lake. It's my most favorite lake in the Lake District.
Thank you very much, Teena.